Well, welcome everyone. Thank you all for taking the time to be with us this afternoon. My name is Katie Junk and I'm with Ochsner Health, and I'll be supporting today's webinar. So just a couple housekeeping items before we get started today. We will have a Q&A at the end of the presentation, so please feel free at any point to drop your questions in the chat or the Q&A function, and we'll be sure to address some of those questions at the end of the presentation. The webinar today is also being recorded, so as long as you registered for today's webinar, you will receive an email with a link to the recording so you can watch it on demand. So as everyone is aware, GLP-1 medication therapy is a very hot topic right now, particularly for employers, health plans, and members. So today we're going to cover a few things. Dr. Kenny Cole is going to give us a clinical perspective on how these drugs work, the clinical value and efficacy, and the population health benefits. Additionally, we're going to dive into the benefits of GLP-1 therapies beyond weight loss and the impact they have on cardiovascular disease, chronic kidney disease, and more. So Dr. Cole will also take us through how Ochsner is balancing these challenges as a 30,000 life health plan and a provider of care, and how we are managing these things ourselves. So to kick things off, Dr. Cole will begin the presentation, but before we do that, I do want to give you a little background on Dr. Cole. He began his role as System Vice President of Clinical Improvement for Ochsner Health in New Orleans in September of 2019. He is a practicing primary care internist and has with advanced degrees from LSU Health Sciences Center in Dartmouth, as well as executive training from Harvard Business School. Prior to joining Ochsner Health, Dr. Cole was the Chief Clinical Transformation Officer for Baton Rouge General Medical Center, where he designed, developed, and implemented a completely reimagined multidisciplinary team-based model of primary care that focused on aligning clinical with financial outcomes. His current work at Ochsner Health built on that prior foundation to design and help develop Ochsner 65 Plus, a group of redesigned primary care clinics focused on the needs of older adults. In addition, Dr. Cole served as the Medical Director of Digital Medicine and Connected Health Programs, which leverages digital technologies to enable remote patient management across a variety of chronic conditions. So without further ado, I will pass it over to Dr. Cole.
Okay, thank you, Katie. Appreciate it. Pleasure to be here with you all today. And let's see, how do I advance the slides there, Katie? There we go. Let's see. Is that it? Okay, good. Hold on, let's go back. All right. Looks like, okay, it looks like there's just a slide delay. Okay, got it. So basically what we'll do today, we're really going to learn about what is GLP, glucagon-like peptide. What are the GLP-1 agonists, which are the medications that I'm sure many of you have heard of and are familiar with. We're going to go through some of the trials, not just the STEP trials. We'll go through a few others, and then we'll sort of shift gears and just start thinking about obesity as a disease and what obesity looks like, across the United States and how it's been evolving. And so what is GLP? Basically, it stands for glucagon-like peptide, which it's an incretin hormone, which helps to stimulate the release of insulin. It's secreted by these cells in the intestine in response to a meal, but receptors are found all throughout the body, including, very importantly in the brain, which we'll kind of get into a little bit because that has to do with sort of our how our brain reacts with food, right? I mean, including a component of, stress eating, emotional eating, the sense of food craving and satisfaction and all of these types of things, right? And so, the effect of GLP-1 in the brain is essentially to indeed act a bit as an appetite suppressant. It sort of calms down the food noise of, we've all had it. If you get these cravings that you just kind of need to sort of try to satisfy, which is usually manifested as like a reward behavior. And so trying to impact that, it does have impacts on the pancreas where it helps to increase insulin secretion, except unlike some of the older drugs like the sulfonylureas, which increase insulin secretion while at the same time hastening beta cell destruction, which are the cells that make insulin, basically the beauty of of this one is that it actually doesn't kill off the beta cells. They still make insulin. It just improves how well the insulin, sort of works. It actually has impacts in the kidney, which, fancy words like natriuresis, which means it helps get rid of sodium, which actually is a good thing. And it can act a bit as a diuretic. It's been shown to be renally protective. It increases insulin sensitivity of muscle, which means it makes muscles utilize insulin more efficiently. It actually, if anything, improves bone health and bone formation. It has beneficial effects on the heart, where it improves contractility, and has been there are studies that we're going to go over that have shown that it makes it cardioprotective, and so the heart functions better on it. And there's also felt to be sort of this anti-inflammatory component to it, where you're decreasing inflammation and some of the shared pathobiology of inflammation, which can cause kidney damage and heart damage, and that are linked through this kind of shared biology. You can begin to see decreases in inflammation there as well. And then of course, the impact on the GI tract is that it slows gastric emptying, which improves satiation and satiety, or the feeling of maybe feeling more full more quickly, and then slowing the passage of food so that it decreases overall consumption. So um, as we go on, let's see, there's quite a delay in shifting the slides. Katie, I may need you to transit through the slides because it's not acting well for me.
No problem. All
Yeah.
right.
Why don't you go ahead and transition? Yeah.
All right. Can you see the next one? We good
Yeah.
there? Okay.
Yep, got it. Okay, so this right here is the timeline. I mean, some of the people think of the GLP-1s as new drugs, and that's mostly because you've seen a lot in the news over the last few years about certain brand names of drugs. The branded semaglutide, which is better known as Ozempic or Wegovy. But these drugs actually have been around for quite a while. Exenatide, under the brand name Byetta, was first introduced in 2005. And then about 5 years later, liraglutide or Victoza, came into the market, and some of the earliest, most favorable studies actually began to mount with liraglutide. Dulaglutide, which was a weekly version, so-called Trulicity, it was a modified version of the liraglutide that could be administered once a week instead of every day. So the liraglutide of Victoza was indeed a daily injection. Semaglutide then sort of came, back in around 2016 or so. So Ozempic actually has been around since 2016. It just really caught on into sort of the press as it basically, we began to see the highest amounts of weight loss, with a drug like semaglutide or Ozempic. Rybelsus is also a form of semaglutide. It's the oral form. And then the other one, of course, I'm sure you've probably heard of. Well, Wegovy is just a higher dose of semaglutide. It's still branded, same drug, same parent molecule as the original one from 2016, just higher dosing. And we'll get into those studies. And then Mounjaro or tirzepatide is also a GLP-1 agonist, but it's also paired with another hormone. And then Zepbound is still tirzepatide. It's just kind of a different dose of the tirzepatide. And now what's important to note here is the tirzepatide has been shown to probably be the one associated with the highest amount of weight loss. So it's probably gotten its own share of publicity. But a lot of the beneficial data that we're going to talk about has not yet been confirmed with tirzepatide. Those studies are still, they're underway as we speak. All right, so we can do the next slide now. And so the only contraindications to GLP-1 agonists are really if there's a personal or family history of medullary thyroid cancer, or something called multiple endocrine neoplasia 2, of which medullary thyroid carcinoma can be a component of that. Or if there's a serious hypersensitivity reaction, like an anaphylactic reaction, then that would be a contraindication. You can do the next one. But the clinical effects we've sort of gone over already, and the big ones as it relates to weight loss are delaying gastric emptying, reducing appetite and cravings, the improved ability to resist or say no to foods. It's kind of, again, that get the food noise out of your head, right? So the next slide. The common adverse reactions, nausea is by far the most common, and most people are going to experience nausea. after, say, the first dose, sometimes after the first few doses, but typically that tends to dissipate over time. In some cases, it can be a little bit more profound or severe, even with some vomiting, in which case sometimes we'll even give, something like a Zofran as an antiemetic. It can cause either diarrhea or constipation, although constipation is probably a little bit more common. Abdominal pain, sometimes nonspecific, fatigue or even gastroesophageal reflux, but those would be the most common adverse reactions. Next. So here, though, first one we're going to talk about is this LEADER trial. The LEADER trial was actually published in 2016, and this is what really started to get the attention of this class of medicines because the GLP-1s, the GLP-1 agonists, when they were first released, they were released as anti-diabetic medications. And so in patients with type 2 diabetes, what we found in this LEADER trial was that it reduced the occurrence of death from cardiovascular causes much better than placebo did. So all those graphs you see on the right is too small, but it's kind of the separation of curves that took place between a placebo and the liraglutide as we saw reduced death from cardiovascular causes, reduced incidence of heart attack, reduced incidence of stroke, reduced incidence of death from any cause, and reduced incidence of hospitalizations for heart failure. And the reason why this was important is because the number one cause of death in diabetics is, most people, when they think of diabetes, they think of the complications of diabetes like blindness or kidney failure or numbness and neuropathy that can lead to amputations. But by far, the leading cause of death in diabetes is going to be heart attack, and then stroke is going to be one of the leading causes of morbidity and disability. And so the ability of these drugs to impact cardiovascular outcomes, that was very different than most of the anti-diabetic drugs we were seeing prior to that. Like you're not going to see that with the sulfonylureas or, the drugs like Actos and, other drugs like that. Like the only drug that had been shown to have even any cardiovascular benefit was one called metformin. But this one now, what we're seeing is not just are we improving glycemic control and we're therefore reducing the things like blindness and kidney failure and those things because of the improved glycemic control. We're seeing kind of this other effect, which is that we're seeing fewer heart attacks and fewer strokes, and we're seeing these kind of heart-friendly effects. And so if you go to the next slide actually looked at semaglutide, which is the parent molecule of Ozempic and Wegovy. And again, this study is, it may be hard to see, but the study goes back to 2016 as well. So semaglutide right along with it was showing kind of the same type of thing, like patients with diabetes, the rate of cardiovascular death, the rate of heart attack, the rate of stroke, all of these are lower in patients receiving semaglutide, much lower than in placebo, which was really kind of lighting up the medical world because, wow, we've got these drugs that are really impacting mortality and cardiovascular mortality, which is the number one cause of mortality total, in a big way in patients with diabetes. Next slide. But then as we go on in this SELECT trial, the SELECT trial also used semaglutide. It used it at the higher doses of semaglutide, which is kind of the Wegovy dose, right? And what that one now showed is even in patients without diabetes, so they don't have to have diabetes, they can be overweight or they have obesity, but in this case, they had pre-existing cardiovascular disease. So they already had some degree of cardiovascular disease. And then now the question that was asked is, since we're seeing such wonderful results in diabetics, what happens in non-diabetics? And essentially, it showed that it was superior to placebo in reducing the incidence of death from cardiovascular causes. So it reduced the incidence of heart attack, it reduced the incidence of stroke. And so we're beginning to really see this common theme emerge with this class of medications. Next slide. Now, this one is the FLOW trial, and this was published just this year. So this is really new data. And the important one here is that the extent of the benefits of the drug is going beyond now even the heart. Because in this case, what happens is semaglutide has reduced the risk of clinically important kidney outcomes, along with death from cardiovascular causes in patients who had type 2 diabetes and chronic kidney disease. So people who had diabetes and CKD already, now what we're seeing is a drug like semaglutide helping to protect the kidneys. So now we know they're protective of the heart, and now we've got data emerging that they're protective of the kidneys as well. Next slide. Now this one I bring because this one, the only reason I put this one in here is because this is the only trial to date that's really now showing tirzepatide, which is the Zepbound or the Mounjaro. That one we know has a really profound impact on weight, a favorable impact on weight. But this one actually was also, this is very hot off the press. This was published, I think, in the last 2 weeks. That essentially what it's showing is that in persons with moderate to severe obstructive sleep apnea and obesity, that they now are getting improved sleep-related symptoms. And this is regardless of whether they were on CPAP or not. And so what happens, CPAP is continuous positive airway pressure, the face mask that people wear connected to a machine. So in those who were either unwilling or unable to they were unable to tolerate CPAP, the tirzepatide showed that it improved their symptoms. And then in patients who were being treated with continuous positive airway pressure, it improved their symptoms as well. And so now what we're starting to see is some emerging data from tirzepatide as well as it gets studied to see if it's showing all of the same effects as of the semaglutide. So the next slide. So now let's just go through fairly quickly. We will go through what's called the STEP trials. And the STEP trials is a mnemonic that stands for semaglutide, treating, I'm sorry, go back one, Katie, I'm forgetting the exact effect. Yeah, the semaglutide treatment effect in people with obesity. That's what STEP stands for. So next slide. So the first of these, the Step 1 trial was published in the New England Journal of Medicine, which is one of our most prestigious journals. This is like the one that I'm reading, every week pretty much. And so this is people who have either obesity or they're overweight. They have comorbidities that are not type 2 diabetes. So by the timing of the trial, like all the beneficial stuff in diabetes had already been published in 2016 and earlier. So now in 2021, we're really beginning to dive into, well, what if they don't have diabetes? And what if we treat them for a long time without diabetes? What are we seeing? And what we saw here was just answering the simple question, do people lose weight if they don't have diabetes? And of course, in semaglutide, there was about a 15% reduction in weight over a 68-week treatment period, so a little over a year, compared to a 2.4% reduction with placebo. Next one. Step 2 was published in The Lancet, which is kind of England's version of the New England Journal of Medicine. That's their most prestigious one. And it was also published in 2021. Similar study design, people who are overweight or have obesity, but in this case with diabetes. And they were showing about a 10% average body weight reduction at the higher dose of 2.4 milligrams versus about a 7% reduction in body weight at the 1 milligram dose. Both of those far superior than the 3.4% reduction with placebo. And again, that was over 68 weeks. Next. Step 3 was published in JAMA, which is another prestigious one. This was also in 2021. And all of these were went underway about the same time and all got published kind of at about the same time. So this one was obesity and overweight with comorbidities, but not type 2 diabetes. And it was comparing the higher dose of the semaglutide, but with the addition of intensive behavioral therapy. So now they're doing the drug plus behavioral therapy. And what we're seeing now is about a 16% reduction in body weight versus about a 6% reduction with just intensive behavioral therapy alone. So next slide. Step 4, JAMA, March of 2021. Again, obesity or overweight, but not with type 2 diabetes. And now what they're doing is they're taking a study and they're kind of bifurcating it and they're giving them the high dose semaglutide for the 20 weeks. And then half of the people stay on the semaglutide and then half of the people come off the semaglutide just to kind of see what happens. And what they saw was about close to an 11% reduction in those first 20 weeks. The people who stayed on semaglutide lost an extra 8%. So you're looking at about an 18% reduction in body weight or 17% reduction in body weight over 68 weeks versus those who stopped the drug did indeed gain about 7% back. So they had about a 5% total weight loss over 68 weeks. Next. Step 5 was published in Nature in 2022. This looked at 2 years worth of treatment at the higher dose of semaglutide and found about a 15% average body weight reduction compared to a 2.5% average body weight reduction without it. Next. So then let's talk just about other changes in like blood pressure, what's happening to blood pressure. We know that when people lose weight, their blood pressure tends to improve. And so this is some of the secondary endpoints of the studies is we know that they're losing weight. What else is happening? And the studies will show that they are indeed experiencing improvements in both systolic and diastolic blood pressure. Next slide. We looked at cholesterol, and what we're seeing here, which is kind of exciting, is we're seeing decreases in the bad cholesterol, which is the LDL cholesterol. That's you want the LDL to be as low as possible, and you're seeing a little bit of a decrease in LDL. But the good cholesterol, which is the HDL, you want that to be as high as possible. You're seeing about a 5% increase in HDL, which is great. And then what you're seeing is about a 20% reduction in triglycerides. And one of the markers that you know somebody's insulin resistant, like I look at this in my patients, is I look at their triglyceride to HDL ratio. A perfect ratio is about 1 to 1. And as that ratio goes up, 2 to 1, 3 to 1, 5 to 1, the ratio that the insulin resistance is rising. And many of those people become at very high risk of diabetes. And so the ability to sort of bring the triglycerides down and bring the HDL up is reducing that whole insulin resistance. So that's entirely compatible with what we would expect to see with a drug like this. Next slide. A1C, I mean, that makes sense that these drugs are improving A1C. They all, after all, they initially were being primarily thought of as anti-diabetic agents, but now, of course, are being thought about across a much broader spectrum of disease. The next slide. And then I wanted to come back. These are STEP trials again, and I just wanted to call these out in particular because they're the two newest ones. So the STEP HEP-PEF trial. So HEP-PEF stands for heart failure with preserved ejection fraction. So these are people who have, now what we're doing is we're kind of going in and being more specific of like, okay, we know how beneficial they are in obesity and diabetes. What about somebody who has obesity and heart failure? And what's happening specifically to heart failure? And so what they did is they used something called the Kansas City Cardiomyopathy Questionnaire, which is basically a questionnaire that's asking about symptoms related to heart failure. So these would be things like how short of breath you are, how far can you walk, how many pillows are you sleeping on, things like that. And what you're seeing with semaglutide was that the Kansas City Cardiomyopathy Questionnaire, that was about an average about 16.6 points favorable, right? So better symptoms of heart failure, and along with the reduction in body weight of about 13%, where placebo, the impact was not nearly as great. And then the next one, the next one is going to be a continuation. It's another arm of the STEP-PEF trial, except this one actually, no, this is the same study. I'm sorry. This is the more detailed. You can see the curves. No, next slide. This one just shows the curves. So you can just see how the curves separate out very nicely. And then last, the STEP-HEP DM trial. This one was one looking at the same thing. This is now looking at patients with diabetes and heart failure with preserved ejection fraction. And kind of the same thing, we see these improvements, but what we also saw now were things like, improvements in the heart failure related symptoms, I think even hospitalizations and so forth. So we're just continuing to see all these benefits, and these studies are ongoing. So like these are just two of the newest, and you can go on to the next slide. And I think we're done with all of the STEP trials. So let's just transition to, is obesity a disease? And sadly and unfortunately, I think there are still some physicians who like don't consider obesity a disease, when the reality is that I think all of our science is clearly pointing to the fact that it is a very complex chronic disease that is really characterized by excessive deposition of fat. That fat can be around the midline or the waist, in which case it's called central obesity. That's probably one of the more toxic forms of fat, because these are people who typically have high rates of insulin resistance, much higher rates of heart disease. We know that fat can accumulate in the liver, and that when it accumulates in the liver, it can actually cause inflammation, and that can even go on to scarring and fibrosis. And obesity is projected to take over as the leading cause of cirrhosis in the United States, probably over the next decade. And part of that is because of that we now can cure hepatitis C with antivirals, and so that no longer is going to be a cause of cirrhosis. Alcohol is still a very top cause of cirrhosis, but even alcohol does it by increasing fat deposition within the liver. And then even people who don't drink any alcohol whatsoever, if they have obesity and they have these increased metabolic deposits of fat in the liver, they have what's called metabolic dysfunction associated steatotic liver disease, or a fancy way of kind of saying metabolic fatty liver. So the American Medical Association in 2013 did indeed label obesity as a disease, and said that there's multiple pathophysiological aspects requiring a range of interventions to advance the treatment of obesity and prevention. Next slide. If we look at its comorbidities that obesity often comes with, type 2 diabetes, of course, there's a very high prevalence because of the insulin resistance. It's an independent risk factor for cardiovascular disease, along with hypertension and hyperlipidemia. Obesity is itself a risk factor for hypertension and lipid abnormalities, as well as for heart failure, especially heart failure with preserved ejection fraction. Although there's some data that there's increased risk of cardiovascular disease, and then cardiovascular disease or ischemic disease, that's going to be the leading cause of heart failure with reduced ejection fraction, because that'll follow after a heart attack. So cancer, obesity is a risk factor for cancer. It's for breast cancer, colon, ovarian, endometrial, liver cancer. Definitely liver cancer, because metabolic dysfunction associated steatotic liver disease, like ultimately it progresses to what's called MASH, or metabolic associated steatohepatitis, which can then progress to cirrhosis. And then once you get cirrhosis, you're at much higher risk of liver cancer, and then it's at a higher risk of gallbladder cancer. It absolutely can contribute to the development of osteoarthritis and then to obstructive sleep apnea. So not only is obesity a disease, it's a disease with tons of coexisting morbidities that are associated with it. So the next slide. So how do we define obesity? It's essentially defined based on body mass index, where essentially it's a relationship between weight measured in kilograms and the height measured in meters squared. So normal body mass index is between 18.5 and 24.9. Overweight is considered from 25 to 29.9, and then obesity is considered 30 and above. So class 1 obesity is a BMI of 30 to 34.9, class 2 obesity 35 to 39.9, and then class 3 obesity is 40 and above. Next slide. And so let's start looking at obesity in the US, and we'll go through these fairly quickly, because what you'll really see here is like, this is sort of self-reported obesity in US adults by state from 2011, and then now 2013. Sort of pay attention to like the changing colors, and then look as the colors are changing, just look and see, that the deeper reds, orange and red is the obesity, right? Greens and yellows are not obesity. And look at what's happening, like even to 2022. I mean, look at what has essentially exploded across the United States in terms of the prevalence of obesity. And so this is an epidemic. I mean, that's what it's being referred to by the CDC and others. I mean, it is an epidemic that is afflicting our population. And so if we now look at the next slide, we begin to just delve into it. Like nearly 1 in 3 adults are overweight, more than 2 in 5 have obesity. And then 1 in 11 have severe obesity, which would be, a body mass index of 35 or above. Next slide. What are the causes? Well, there's multiple factors, right? Genetics clearly play a role. Social and economic factors play a role. Even things like adverse childhood traumatic experiences can play a role. So things that happen to a child, right, prior to, traumatic things like, just things we would never even want to think about, happening to our own children, that what happens is it impacts how their brain is wired, and it impacts, with their diet intake and their energy balance and so forth. So there's all of these things that come into play between socioeconomic factors, genetics, environmental factors, how much exercise we're getting on a daily basis, how much energy are we burning. And then there are sometimes other medications and other disease processes that can play a role, but it's really a complex multifactorial situation here. Next. And then what's driving these rising rates of obesity? Probably some of it is that people are cooking at home less. They're increasing in restaurants and in fast food. Sometimes just, it's about speed, right? And convenience and how quickly can we put something together. And unfortunately, that often ends up being, frozen meals or prepackaged meals that are highly processed, and they're meant to be quick and convenient. But the trade-off is that a lot of that processing is altering, the quality of the food in a way that's clearly driving some of this obesity. Food portions have increased, activity levels have decreased. I mean, with the transformation of an economy, which was, a lot more maybe industrial and manufacturing into more of a knowledge economy where the jobs are less labor intense and there's more, sedentary and desk jobs. An increase in passive entertainment of people just watching television with all of the explosion of the options that are available there, video games, the internet. So these all play a role in sort of what's driving obesity. Next. And then you can kind of look back at sort of, portion sizes, whether it's a beer or a Hershey bar or, McDonald's French fries or a Whopper or even just something like, Coke or soda. The sizes, the choices of sizes, have been made more available. And look, these companies that make these products, they're trying to drive a bottom line profitability. And if they're going to sell a product that's going to sell more and they can make more money off of it, they're gonna have incentive to do that. And then also what's happening is food science. I mean, like basically, these companies all employ people whose job it is to, tweak portions of fat, salt, and sugar in a way that takes advantage of something called the mesocortical limbic system within the brain, which is basically sort of like drives dopamine release and a feeling of satisfaction, right? Many people will eat, when they're stressed out, and that's just a common fact of biology. And part of the relief that comes from eating is, for some people it's chocolate, for others it might be alcohol, for others it might be salt. But, there's a loop that takes place in the brain that you get that sense of satisfaction, you get a release of dopamine, and then it becomes sort of a coping behavior, a coping mechanism. And then, and so the experts in food science who have figured out how to manipulate those levels of fat, salt, and sugar have done a great job if the job is to try to get people to consume more food and increase the sales of the products that the food companies want to sell. Next slide. But those costs to society are pretty profound. And so if you just look at each 1 unit increase in BMI over 30, there's an additional about $253 per person cost of each incremental unit as BMI goes up. And so it's associated with almost a $2,000 excess annual medical cost per person when averaged out across people with obesity. And then severe obesity brings it up even more, over $3,000 per person. And the total cost of chronic diseases due to American obesity is estimated to be as high as $1.7 trillion when you factor in now all of the associated diseases, right? Whether that's cardiovascular disease, diabetes, hypertension, osteoarthritis, and the joint replacement surgeries and the liver disease and the, cirrhosis and liver transplantation. And, you start adding all of that up, and obesity plays a role in driving a great deal of that cost. Next. And so what this slide really just does is show sort of the increments in cost between those who are not obese. Like if you look in that upper left-hand corner, total expenditures over time, somebody who's not obese versus somebody who suffers from obesity. And then as you move and look at like the other slide, like the purple line would show kind of someone with severe obesity. And so just showing kind of these incremental increase in costs that go up over time and correlated with the severity of the obesity. Next slide. So Ochsner, in addition to being a health system, we're also, we are self-insured employee health plan. So we have about almost 40,000 employees, 38,000 employees. And so we, as all self-insured employers, we struggle with the same issues. Like how do we control, total cost of care for members of our own employee health plan? And we actually have opted for the clinically appropriate use of GLP-1 therapy, which is where members will receive coverage for the GLP-1s if they're enrolled in our own specific weight management program. So this is a remote weight management program that's operationalized through our digital medicine arm, where we're actually using GLP-1s as a medication to complement concurrent behavioral change strategies, right? Where, nudges and interactions with, health coaches and others to try to sort of do a combination of a behavioral plus medical approach. The medication management is overseen by licensed providers. And, we actually did a survey that found 44% of people with obesity would change jobs to gain coverage for treatment. So next slide. Ochsner's weight management program. So we do provide both medication and lifestyle intervention. So the base weight loss program is that a person, has to be an adult. They have to have a body mass index of above 25. There are some exclusionary criteria, like if they have an eating disorder, medullary thyroid cancer, things of that nature. Now, what happens is I mentioned the body mass index above 25. That's for the weight loss program, so that's not the medications. Okay, if you do the weight loss medication, we actually will use a BMI of over 27 if they have corresponding obesity related issue like osteoarthritis or diabetes or hypertension or something along those lines. Otherwise, even if they have no corresponding issues, if they have a BMI above 30, then we will prescribe both the medication and the base weight loss program, which is the behavioral modification program. We do a virtual visit just in order to kind of test out the acceptance criteria, make sure there's no exclusionary criteria that would disqualify them for that. And then if all of that's met, then they would become eligible for the medication. The next slide. So it was developed, in partnership with our Bariatric Center of Excellence. Of course, we're an 80-year-old academic health system. But the patient has an initial call with a registered dietitian where we offer the nutritional counseling and some remote digital coaching, and then the GLP-1 therapy with oversight from our clinicians. We also offer an app with the opportunity to, track food and look at what their meals are doing over time. And then we have quarterly reporting, which includes the number of patients enrolled, their engagement metrics, and then, of course, program success measures like weight loss and so forth. Next slide. It's our goal is really to engage effectively with every member, matching them to the right clinician and or registered dietitian based on their specific needs within the cardiometabolic spectrum. So, optimal health, they don't need anything, but once they get into that overweight stage and then especially as you progress and they become overweight with, let's say, the hypertriglyceridemia, or they overweight and now they have the hyperlipidemia and they have hypertension, or, let's say they continue to progress and they have obesity and they have not only hyperlipidemia and hypertension, but they have diabetes. We're managing all of those patients within sort of this cardiometabolic disease spectrum. And we're really, just trying to prevent downstream complications of these diseases that we believe are going to be far more expensive than the money we're spending on the medications and the rest of the program. Next slide. So, our ethos is it's kind of this fusion of sort of the perfect marriage of human connection and digital connection, right? So it's about some personal touch, evidence-based care, and just a commitment to every member's well-being. And so it really becomes a clinician-member partnership, right? Where they're paired with, a dedicated Ochsner clinician who's credentialed in their state, following the evidence, as the clinician and the health coach address and try to counter all of these kind of reversible causes of disease using data and detailed personal and social history to provide education and support, meaningful lifestyle change and completion of their goals, and then optimizing medications with the latest evidence-based guidelines. And we do that, for like our hypertension, we do that for diabetes, we do that for obesity. Like we're always making sure that we're following the absolute most up-to-date current evidence of what is considered to be clinically appropriate for how these medicines are prescribed. Next slide. what do we have to show for it? I mean, thus far, just looking at like our other programs like diabetes and hypertension, we'll see about 80% of our patients with hypertension and 80% of our patients with diabetes achieving their goal blood pressure and A1C within a 6-month period of time. And an independent actuarial assessment calculated that out to be about $2,200 per member per year savings, with about a 3-to-1 return on investment. And part of that return on investment is coming from avoidable utilization reduction, where what we've seen is 45% reductions in emergency room visits for our hypertension members, 38% reductions among our hypertension members, 30% reduction in ER visits for diabetics, and 15% reductions in hospital admissions for type 2 diabetes. And along with that, a net promoter score, that's typically in the around 87 or so forth. With some of the, compare that to where Netflix or Amazon is at 68 and 62. I mean, we're trying hard to make sure that we're doing this in a customer-centric way that's meeting the needs of our customers and addressing their pain points and challenges. Next slide. So with that, questions?
Thank you, Dr. Cole. All right, so we'll move into our Q&A time. We have about 15 minutes for questions. So if anyone has any questions about anything you heard about today, feel free to pop those into the chat or the Q&A, and we'll get those addressed. Oh, it looks like I do have one. It says, how does this program compare to some of the other popular point solutions?
So say it again. Katie, repeat the question for
Yeah,
me.
absolutely. The question was, how does this program compare to some of the other popular point solutions?
Yes, I think part of what we're doing that I think is pretty different. I don't know of many point solutions out there that are incorporating medical management into the solution. Like so a lot of the point solutions out there are remote monitoring solutions that they're monitoring, they're getting data, whether it's blood pressure, sugar, or weights, they're getting data, they're collecting data, and then they're trying to do it with, behavioral, nudges, meal planning, well-intentioned, types of ways to influence and impact human behavior. What we're doing is really, ours is not remote patient monitoring. Ours is really remote patient management, because we are embedding, a monitoring element with a medication management element, right? Leveraging our ability as a health system, to draw upon clinical knowledge and clinical expertise to be able to then drive, medical management in that in a clinically appropriate way. So I do believe ours is meant to be much more, holistic in nature. And part of what is happening out there in the world is, and I know this because I did primary care. I was on the front lines of primary care for well over a decade. And I know from my years of practicing primary care, there were never enough hours in the day to do everything I would have wanted to do with all of the patients who were claimed to be, my patients. I wanted to, but the studies have been done that show for a primary care physician who's taking care of a panel of 2,500 patients, the number of hours that it would take to do all of the evidence-based, clinically appropriate treatment that is recommended, whether that's preventive health counseling, chronic conditions management, seeing the sick people, et cetera, it would take 26.7 hours per day to do all of that, which is a mathematical impossibility. And so trying to be more holistic by understanding that the standard primary care, at least the way it's paid for and the way it's been operationalized by virtue of how it's paid for, can't do it all alone. And so how do you devise, as a health system that understands that, how do you devise support solutions that sort of, overlay or can link back to that and be, be part of a much more well-rounded program? I think that's how we're seeing ourselves as different.
Thank you, Dr. Cole. Another question here. You spoke of environmental impacts in drivers of obesity-related consumption and unhealthy food. How is Ochsner as an employer addressing this in addition to the pop health solution with GLP-1s?
Yeah, so a couple of ways. I mean, one, we are actively, I think, trying to sort of change the food choices that are available, as a health system. Like I know there's been a big push, for to try to do that. So what are the choices that are available in our cafeteria and our vending machines, and just so trying to make those types of things. The other is, and this may not be the answer you're looking for, but it is to try to understand that we've got to meet all of our patients where they are, and we understand that there have been flagrant healthcare disparities and just inequalities and how like who has access to healthcare, whether it's somebody living in a food desert, and like that has existed, we think, for too long. And so, building out the infrastructure of our community health centers, incorporating community health workers into our community health centers, going into communities that have been traditionally neglected and trying to embed ourselves there, and then bring social workers into those models that are sort of like how do we help, how do we actually, we're already like collecting data on social determinants of health, and so looking at all of those factors, and then how do we then begin to drive actual interventions and plans based on that data that we're getting, whether it's being there in a community health center where we're servicing a population, and understanding that things like social and economic factors act as obstacles, barriers, and challenges to people achieving their optimal health, and then just trying to begin to think creatively of, okay, how do we overcome these obstacles, barriers, and challenges? And it's, look, we're a big health system, and so I'm not going to say we move, as quickly as we would like, but clearly we move deliberately and methodically in a way that understands that it does have to change, which unfortunately is not the case with some other systems that are out there and ways of thinking.
Thanks, Dr. Cole. All right, we have a two-parter here. Is the ROI specific to GLP-1 utilization for weight loss or your cardiometabolic program in general?
Yeah, the ROI mentioned in the presentation is specific to the cardiometabolic program that it really was in place. That was an actuarial study done with our hypertension and diabetes programs, and that was prior to the launch of this weight management program.
Perfect. Thanks, Dr. Cole. As part of the two-part of that question, it says we've seen high discontinuation rates of GLP-1s for weight loss relative to people taking for GLP-1s for type 2 diabetes in an employer population. How is the program improving this?
Yeah, so I think that's part of the screening process, right? So I do think that's part of the data that we're collecting, and why we're going through a process where we're getting a lot of information from the person up front and in advance. I think that so there's that sort of initial sort of enrollment, process, if you will, that's done primarily digitally. Then there's the actual then connections with, the dietitians and health coaches, like those types of things, followed by the prescribing of the medication. And so typically a patient has already sort of begun in the program where they're already tracking their meals, and they're already, kind of, it's beginning the parts of the behavioral change, sort of part of the program before they ever even get to meet, with the actual clinician, and before they get prescribed the medications. Um, and I think the other thing is just when there are, just part of it is preparing, like if there are indeed um, side effects or complications that arise, making sure that there's a mechanism for the patient to contact about it and ask questions, and even potentially get prescribed antiemetic therapy like a Zofran, things like that. Just trying to do as much as you can to help these patients be successful.
Thanks, Dr. Cole. We have another question that says, can your program reverse diabetes?
So it's a great question, and the answer is essentially yes, but let me clarify it. Okay, so diabetes, we really know that diabetes is on a spectrum, right? So you have anywhere from, say, normal, like, so say a hemoglobin A1C, which is one of the measures of the average amount of blood sugar that's in the bloodstream. A normal hemoglobin A1C is anything less than 5.7, so that would be considered normal. 5.7, an A1C of 5.7 to 6.4 would be considered pre-diabetes. And so the word pre is intentionally used because you're not yet diagnosed with diabetes, but we know that that is a path on this sort of this metabolic continuum that if it continues, if a person continues to gain weight, they continue to exhibit higher levels of insulin resistance, it's probably just a matter of time before they advance on that spectrum. And the A1C, once they have an A1C of 6.5 or higher, that is indeed a diagnosis of diabetes. Now, what I will say is that once a person has been diagnosed with diabetes, we don't go back and undiagnose them and say, okay, we got their A1C down to 5.2. They're no longer a diabetic. The answer is they still are a person with diabetes. It's just that they now have a normal A1C, and that clearly has been reversed. And so they are currently they have what we would call well-controlled diabetes. And the goal of controlling diabetes is in large part to prevent a lot of those complications we talked about, whether that's blindness, it's the leading cause of blindness in this country, whether it's kidney failure, whether it's, the numbness that can lead to an amputation, or whether it's heart attack or stroke. The better you do at controlling the diabetes, the better you can at preventing some of those complications, especially when you're using medications that have been proven to have, an independent cardiovascular benefit.
Thanks, Dr. Cole. So with these drugs being around for nearly a decade now, why do you feel like now there's been such a resurgence, like in the media or even the use of these drugs? Like, why do you think there's been such a
Well, I think that's multifactorial, but and some of it is probably clinically inappropriate use of these drugs, quite frankly, right? I mean, what you're seeing to some extent, we all hear the stories of someone who takes it because they were trying to fit in a wedding dress or a bridesmaid dress or, something along those lines, where are these actresses, Hollywood, I mean, all of those types of stories. And so I think that some of that sort of glorified and sensationalized the drugs. I think that's really truly unfortunate because I think there is a clinically appropriate way to use these medications, and I think there's a clinically inappropriate way to use these medications. And what is intrinsic to this conversation is that I know we are only going to use these medications when clinically appropriate, which is that they have to meet the criteria that have been studied within the literature, that have been proven. And so that's going to be the body mass index above 30. It's going to be all of the stuff from patients with diabetes or whether they have heart failure. I think what's also interesting is the patients who are the patients, and I don't think we know the answer to this yet. I think we're just early on. Who are the patients that absolutely are going to need like lifelong therapy, because there are going to be patients, whether it's like the patients with heart failure and some of those, like if you've already got heart failure, you're not getting off of these medicines. Like you need to be on these medicines. It's going to keep you out of the hospital. It's going to help improve your mortality. It's going to prevent you from dying. Whereas I think there are going to be segments of people who don't necessarily have an indication for, say, like lifelong therapy and what is going to be the right path for them. And how many of those through the behavioral changes are going to get, to a point where they can potentially, be off of these medicines and stay off of them versus which ones may take them intermittently. Maybe instead of every week, it's once every 2 weeks or once every 3 weeks, unfortunately, we don't have all those answers yet. But those are the types of things we'll be interested in looking at. I can tell you the patients who we won't want to see come off of them are going to be the patients who have evidence-based indications due to a chronic condition that we know could potentially keep them out of the emergency room, keep them out of the hospital, reduce their risk of heart attack, reduce their risk of stroke, and so forth. And so for those patients, we're going to want to see them stay on the drug.
Thanks, Dr. Cole? I think this is a good segue into the last question. Think about putting this program in place to, contain costs, making sure members are getting clinically appropriate care. But, for a self-funded employer, was some of these newer trials really indicating that these drugs have a greater benefit than just weight loss, but they're more protective therapies for the heart and the kidneys? What does that mean for a self-funded employer in terms of, being able to offer these drugs, to their member population? Like, what is the downstream effect of that?
Well, the hope is, and it's again, it's one of these complicated things, right? Because I believe that what the data will eventually bear out is that the drugs, because of their, the nephroprotective and the cardioprotective and all of these other types of effects that we're seeing, I think we're going to see a total cost of care, come down as a response, from these. Now, the difficult decisions are the actuarial decisions, which are how long is a given member of your employee with you in your health plan? Like how long are you insuring them, and are you covering the cost of the drug for a couple of years only for them to leave your plan, and now all those benefits get accrued to someone else. This is what the commercial insurers struggle with, right? Like they have such a high turnover, even in their fully insured book of business. They have such a high turnover across their plans that they struggle with these coverage decisions, because the coverage decision is really the longevity of the member, and how long are we going to bear the burden of this cost for this member, and is the benefit going to accrue to somebody else? And that one I can't answer for you. What I can tell you is what we've done as a self-insured and health plan is to kind of view it from the idea that look, competition for good talent is tough, and what we want to do is hire really good employees, and we want to keep them. Right? We want them to be happy. We want to be engaged. We want them to come to work every day and be productive. And we're willing to make this investment in them and their health, in the hopes that it is going to pay off for us in multiple ways, through their improved health, improved engagement, and hopefully ultimately in total cost of care, as we make these investments in what we know is clinically appropriate use of an evidence-proven medication.
Excellent. I want to be respectful of everyone's time. It is 2 o'clock. Dr. Cole, thank you for being here today. Everyone that attended, thank you for being here. We will be sending out an email with a link to the recording, so you can watch for that in your inboxes. But hope everyone has a great rest of your day. And yeah, thank you all for being here. All right, thanks, Dr. Cole.
Thanks. How you think it went, Katie? Good.